This is diffuse lung disease number 6, prepared by Prof. Sharaf and revised by Prof. Yusriya Sabri. We'll talk about chronic obstructive pulmonary disease, asthma, chronic bronchitis, emphysema, bronchiectasis. Hypertranslucent lungs can result from deficient chest wall soft tissue like mastectomy or Poland syndrome. Technical factors: obliquity, decreased pulmonary blood flow volume as in emphysema, or decreased pulmonary blood flow volume unilaterally and as in Swyer-James syndrome, and increased resistance to flow as in asthma. All of these may decrease the blood flow, resulting in increased radiolucency of the lung. This may be unilateral or bilateral. Emphysema. This is abnormal enlargement of the terminal air spaces distal to the thermal bronchioles with alveolar wall destruction. So here there is no wall. It's classified into 4 major anatomic subtypes. Centrilobular, that means it is involving the alveoli within the center, and this is upper lobar predominance, seen in cigarette smokers, and usually contain bulle. Pan-acinar or pan-lobular, it's usually lower lobe, and it is related to alpha-1 antitrypsin deficiency, sometimes associated with bronchiectasis. Paracicatricial, that by the name, it is near to a scar. Paraseptal, that is multiple subpleural bulli in single layer of less than 1 centimeter. So what is usually we are seeing is the pan-acinar or the pan-lobular emphysema, which is diffuse and lower lobe predominance associated with the bronchiectasis. The centrilobular is related to smokers and its upper lobar. The paracicatricial need to have a scar to be pulled, and paraseptal means it is something subpleural, appearing as multiple subpleural bulli of less than 1 centimeter. The complication of emphysema as a whole is cor pulmonale. So what is this? This is a diffuse upper lobe predominant type, and this is what we call the centrilobular, diffuse upper lobe, centrilobular. Usually patients are cigarette smokers, and we can see small bulli scattered in both lung fields. What is this? This is middle zonal, and this is, here we have the pan-acinar, and the pan-acinar is a diffuse or lower lobe predominance. It's widespread lucencies, and sometimes there is bronchiectasis. So this is the pan-acinar emphysema. This is the centrilobular emphysema, multiple bulli at the upper lobes related to cigarette smokers, and here it's lower and middle zonal, very wide spread translucencies with sometimes there is bronchiectasis. Here we can say that this is the paraseptal. It is bilateral subpleural, bilateral subpleural. This is paraseptal. bilateral subpleural with small bully. And this is cicatricial. Of course, this is a case of asbestosis, silicosis, and you have what is known as the progressive massive fibrosis. Now, bully is more than 1 centimeter, is wall thickness less than 1 millimeter, could be primary bully, usually upper zonal, associated with the emphysema. Type 1 beneath the apical pleura, type 2 beneath the anterior pleura, type 3 within the lung. So we have 3 types of bully, either near to the apex, either anterior or within the lung. Complications, of course, spontaneous pneumothorax. Associated disease, we have a lot of associated diseases, including neurofibromatosis, Ehlers-Danlos, Marfan syndrome, and aortic stenosis. Quickly we will revise: centrilobular, upper lobe, smoker related; pan-acinar or pan-lobular, diffuse, mid and lower with bronchiectasis; cicatricial, near to fibrosis; paraseptal, mainly subpleural bully of less than 1 centimeter in diameter. So this one is the centrilobular, upper zonal, smoker related, multiple small bully scattered in both lung fields. And this is the pan-acinar, widespread translucency, may be associated with bronchiectasis affecting lower lobes, middle and lower lobes. And this is the peripheral type, or the paraseptal emphysema, where you can find bully of less than 1 centimeter in diameter, of around 1 centimeter in diameter, and it's mainly subpleural paraseptal. And this one is the cicatricial, related here to a case of silicosis with progressive massive atrophy. Bully could be divided according to the location. If it is near to the apex, it is type 1. It is anterior, it is type 2. If it is within the lung, it is type 3. The main complication is pneumothorax. It can be associated with a lot of diseases like Marfan, Ehlers-Danlos, and neurofibromatosis. Here we have a giant left upper lobe bulla. Here we can see different types of mid and lower zonal pan-acinar emphysema. And to diagnose emphysema, we have barrel-shaped chest, we have transversely oriented ribs, we have lower level of the diaphragm, and if you trace the vessels while going out, you will hardly be able to see any, especially in case of emphysema in chest X-ray, while normally you can see it in the medial third, see it, trace it to the middle third, and hardly you can see in the outer third. But in emphysema it is hardly to be seen in both middle and outer thirds of the lung. May be associated with pulmonary artery dilatation, as in this case, denoting cor pulmonale. So barrel-shaped chest, transverse placed vertebrae, low level of the diaphragm, and the attenuated peripheral vessels, so you hardly see any vessel in the middle and outer lung zones. In the lateral film, don't forget the flat diaphragm, the increased retrosternal airspace. Normally it is 1/3. It may reach to 3/5, and increased retrocardiac airspace. Normally it is width of one vertebra. It may be increased more than that. So all of these are signs. A nice sign also is the angiographic appearance of the aorta in the lateral film in case of emphysema, the accentuated density of the aorta. This is a nice sign which can be sometimes mentioned. And of course we said about complications, mainly pulmonary. Bronchitis could be associated. Now coming to another subject is the lymphangiomyomatosis, which occur in childbearing period and usually diffuse thin-walled round lung cysts. Could be with pneumothorax, could be with chylous pleural reaction, lymphadenopathy, and renal angiomyolipoma. And the only thing you can see in the X-ray is the hyperinflated lung. And of course, it may be considered as a form of phacomatosis. Here it is. What sort of this is? It is the extensive centrilobular pattern. Extensive centrilobular pattern. So in lymphangiomatosis, it is mainly the extensive centrilobular pattern affecting the middle and lower lung zones, or diffusely affecting the lung. Now coming to bronchiectasis, irreversible dilatation of bronchi, may be localized as TB or fibrosis, as we call it, traction. All cases of interstitial lung fibrosis, interstitial lung disease may end with honeycombing and traction bronchiectasis. It may be diffuse, cystic, as in cystic fibrosis or post-infection, or the dysmotile cilia syndrome, or aspergillosis, may be diffuse bronchiectasis. It may be related to pulmonary fibrosis, as we said, and the differential diagnosis is the fingered glove appearance mucocele. To diagnose it, we can say that the finger glove appearance mucocele filled a dilated bronchus with mucus plugs, and signet ring appearance, a dilated bronchus related to a normal sized vessel, tram line appearance, tram tracks appearance in cylindrical type, cluster of grapes in cystic type, string of pearls in varicose type. So these are the descriptions for bronchiectasis. Association with bronchiectasis and emphysema could be seen, and this is a case where our bronchiectatic changes occur in an emphysematous chest. Thus, both are considered part of chronic bronchitis syndromes. We might get diffuse congenital bronchiectasis, and the differential diagnosis of cystic lung should be considered. Now come to cystic fibrosis. In cystic fibrosis, abnormal exocrine salivary and sweat glands and airways and pancreas with various viscous secretions result in recurrent infection, usually upper lobar. There will be hyperinflation, atelectasis, pneumonitis, finger-like gloved finger appearance of mucus plugs, upper lobe tracking, and peribronchial coughing due to bronchiectasis. It is associated definitely in bronchiectasis with upper lobe fibrosis. Histiocytosis is an idiopathic disease of young adult men, include upper zonar nodular and cystic pattern, similar to the other one, but we have many types. Neonatal literacy with hepatomegaly and lymphadenopathy, multiple cystic bone lesions, acute disseminated form is rapidly fatal. Children has hand-titular crystalline disease with exophthalmos and diabetes insipidus, lytic skull geographic lesions, and the adults has eosinophilic granuloma manifesting as lung and focal lytic bone changes. This is histiocytosis, which may be complicated with pneumothorax. Again, it is pan-acinar with bronchiectasis, cystic changes. Tuberous sclerosis. Here we have the subependymal calcifications. The patient is an epileptic retarded dyspneic female, and the differential diagnosis of such an appearance of cystic parenchyma is the lymphangiomyomatosis and the eosinophilic granuloma. This is a typical tree-in-bud appearance of tuberculosis. Tree-in-bud appearance seen in tuberculosis. This is the miliary shadowing and the tree-in-bud and bronchiolitis. Random nodules in miliary TB. Random nodules in miliary metastasis. For example, reticulum cell sarcoma or thyroid. Now coming to invasive pulmonary aspergillosis, which usually behaves like TB. So we have the angio-invasive type and the aspergillus bronchiolitis and the bronchopneumonia. The angio-invasive type, we have consolidations with halozones, wedge-shaped pleural-based areas of consolidation with cavitation. The aspergillus bronchiolitis and bronchopneumonia is patchy peribronchial and lobular consolidations and tree-in-bud pattern, so it is near to that of the TB. This is the appearance of nodules with halo in invasive aspergillosis, in which we can find nodules or focal consolidation with halo signs and wedge-shaped opacities with pleural-based, sometimes cavitating. Any of these can cavitate. Tracheal dilatation. You know that there are two types of tracheal dilatation. Tracheomalacia, if it is focal, usually due to intubation, and diffuse, as in Munir-Kohn syndrome or pulmonary fibrosis. Of course, there is association with IPF and congenital tracheobronchomegaly. Thank you.